It is my privilege to introduce our first speaker, and that is Dr. Howard Backer. He's the director of the California Emergency Medical Services Authority and leads the department in establishing evolving standards for EMS personnel, coordinating with local EMS systems, overseeing the development of statewide care systems, and preparing for and responding to disasters. Dr. Backer told me to keep his introduction short, so I'm going to leave it short. And Dr. Backer, the California EMS Authority's director.
This is very exciting. If for those of you who don't know, we actually started out this entire project with a meeting, not as large as this, but with a meeting of many of you in this room, just to visualize and start to envision where we wanted to go and what we wanted to accomplish in California. So just to kick off this day, which is going to be very exciting to hear, for everyone to hear, not only how these projects have been going, but what our vision is for the next steps and for the future, and what value these could bring to our health systems and others. We're going to get to hear all that and have some discussion and some interaction in there. But I want to let you know kind of what got us up to this point. Our current EMS model is really antiquated. I kind of call it the system that's frozen in time. Because the payment rules were set back in the 60s. The model was set for EMS back in the 1970s, and it was based on a transportation concept. And it's still, to this day, the federal government considers EMS a transportation service, not a healthcare service and healthcare providers. And that is the crux of our whole issue here and what we're trying to demonstrate by these projects. And you'll hear more about this, I think, from Matt Zavadsky. But what it comes down to then is that our EMS system uses the most expensive possible means of taking people to the most expensive place of care. And you all know that our health system now is really looking desperately to become more cost-effective, more efficient, and more successful and effective for patients. Well, the federal government has finally recognized the potential for EMS. And a white paper was put out by the Health and Human Services and a bunch of other federal agencies that are invested in healthcare, and they started to see that we could do more than just taking people to emergency departments without any other kinds of options, and that we have a unique position and responsibility within the healthcare system that would allow us to help better coordinate care and determine more efficient ways of providing care to individuals. Some of those begin at dispatch with the first call to 911 by potentially triaging patients at that first call. And then you'll hear as many of our programs have taken some of these other approaches as to, are there other ways that we can maintain the health of these people or refer them to other kinds of resources that might better meet their needs. Especially the idea is, instead of just being linked with the emergency department and emergency care, can EMS partner with other types of services in our communities to better serve our patients? So the definition that we set and that has been developed for community paramedicine, and I use the word community paramedicine, but there is another term, mobile integrated healthcare, which is pretty equivalent. And going forward, which term we use, I think, is a matter of choice and policy. But we set this definition that it had to be a community-based, a model that is based on integration with other services and other parts of the healthcare system, and to optimally fill gaps and optimally integrate the various kinds of services available. But why do we think that paramedics are well suited for this task? Well, I think this group in here would know the answer, but you may not have actually stopped to think about it, how widespread paramedic services are in our communities and how available they are. And not only that, but they're used to going into people's homes. That's one of their regular sources of service or locations of service. And they're trusted and accepted by the public. You rarely hear of people protesting or denying paramedics access to their families or their loved ones. And they are a licensed health care provider. And very important for this is we work under medical control. So we're tied at the hip with our other medical providers, mainly our medical direction. There are many models and types of programs for community paramedicine that have been developed not just in California, but these were mostly developed in other parts of the country. And we gravitated towards certain types of projects. We did not dictate when we started this what the projects would look like. We asked for proposals that had to be based on basically a community needs assessment, on working with your community partners to determine what would be the best function, what is the service that you could best provide to fill a gap in the health system. So the ones in dark here are the ones that ended up as California projects. The ones in lighter were ones that we did not use here in California, at least in these pilot projects. For example, there are no projects that are actually putting a nurse in 911 dispatch to triage and screen out calls. Reno did this as part of their pilot projects, and other parts of the country have done that. Nor did we have, unfortunately, we did not have some very rural areas using paramedics as kind of community health providers for either preventive care or ongoing care. But in other parts of the country, those models are being used. Here are so there's pre-hospital ones that we were just looking at, pre-hospital models of care, and post-hospitalization community models of care. But our pilot projects do encompass most of the current models for community paramedicine or mobile integrated health. Now, why can't we just open this up and say, go for it? Anybody's available. Well, it's because in California we have a particularly limiting paramedic practice statute. And the key language is in red there. It's not just the scope of practice. The scope of practice is quite broad, but this designates the role, where it can be practiced and under what conditions, and it's at the scene of an emergency during transport to a general acute care hospital. That's where our limitations are. So it kind of narrows down our potential destinations where we can take patients, and narrows down the settings in which we can evaluate patients. So it doesn't say anything about post-acute care or routine follow-up of patients and taking them to other destinations. And so then the question is, well, why did we turn to OSHPD, our Office of Statewide Health Planning and Development, one of our sister departments within the Health and Human Services Agency? Why did we turn to them for this health workforce pilot project? Because it turns out that they have a statutory program that was custom made for us. There were some very visionary lawmakers. Lawmakers did used to be visionary back in the days, and in the 80s they set up this program kind of almost in anticipation of the healthcare reform that we'd be going through now. And this program was actually to use healthcare personnel in new roles and reallocate healthcare tasks to better meet the needs of the citizenry. What a perfect description of what our community paramedicine projects are all about. And you'll notice it says publicly evaluated projects, and we did have to have 2 public hearings before we started these projects. The advantages of using this pilot project were, one, because we couldn't just do it on our authority. We don't have the authority to override the California practice statute, but it allowed us to test a variety of options and test the feasibility within our very specific healthcare system within California, which is pretty unique among the other states in the United States. So whereas other states could just start these up, like you'll hear about Texas, it's like open range there. Whatever you want to do, you can pretty much do. We had to do this, and we had to test it within our unique arrangement of healthcare organizations and systems in California. But this project also is very intent on assuring patient safety and allowed us to create partnerships and collect data to develop the evidence to change policy in the future. The requirements that we had set and that all of these projects had to meet was that they had to be collaborations and partnerships. As I said at the beginning, to even come up with the type of project they wanted to do. There had to be additional education and training. And then we said that these should not compete. We don't want to try to shoulder and barge our way in and push someone else out of a healthcare provider space. Not that there's not enough work for everyone to do, because there's plenty of need in our healthcare system, but we did not want to try to supplant some other healthcare provider. These are collaborative projects, not competitive. Then OSHPD, in reviewing the initial applications, set some other requirements. They required that they all have research board approval, investigational research approval for each of the projects. They required patient consent, but very importantly, since many of our projects deal with disadvantaged people and substance abuse, that they exempted patients who could not consent because of intoxication, which was very helpful for some of our projects. And they wanted more consistency. I mean, although there's a variety of projects, at least among the projects that were attempting on a similar model, they wanted similar protocols. So the protocols had to be, we had to get the medical directors together to develop a little more consistency in the protocols for alternate destination and for post-acute care evaluation. They wanted additional data points from what we originally submitted or proposed, and they really were emphasized, again, the public safety and concerns about notifying them right away of any safety concerns. Well, I think this project, I've never seen a project with so many levels of safety evaluation built in. And these are the many levels of safety that we engineered into these projects, that you engineered into these projects. And it begins right at the provider level, where they're reviewing all of the cases, and goes up to the steering groups and up to our agency and OSHPD. So there were many eyes on these projects. Well, this was not without controversy, and during our public hearings, and OSHPD has to take public comment in about these projects, there were many objections, and the top one was that, this is dangerous for the patients. It's a patient safety issue because the paramedics can't really make these kind of decisions safely. Well, we knew that not to be true because that's what you do on a day in and day out basis is evaluate patients and make decisions for do you need a rapid intervention in the field and what kind of facility are you gonna bypass your closest facility for a specialized facility. So we knew that didn't carry it. That was just blowing smoke to try to protect their own turf and their own their own sense of their particular professional realm of responsibility. And the nurses, of course, thought they were the ones that should be doing this. The doctors thought they were the only ones that could determine when a true emergency existed. And the most interesting one was this last one, was that a patient who calls 911 expects and deserves to go to an emergency department and an emergency department only, that these were inextricably linked, not just in policy, but in standard and best medical practice. So anyway, these are the pilot projects. You're going to hear about these in detail, but these are the pilot projects and the sites where these projects were carried out. We didn't have, there were other, we would have liked some more rural sites. We would have liked some more sites in Northern California Bay Area, but I think we got a fairly good diversity geographically and population-wise, and we got a really good diversity of types of projects, so that we're not just looking at this in a narrow, from a narrow perspective. We're looking at a spectrum of potential types of programs that could fall under this, under community paramedicine or mobile integrated health, if we're able to expand the practice role. I want to give an acknowledgement to the California Healthcare Foundation, whose vision helped to support this program and to encourage this program. You'll hear from Sandra next, who will explain why this is aligned with their vision of healthcare policy and practice in California. But they not only supported the role of Lou as project manager, but they supported the role of Dr. Kaufman, who you'll hear from, for the independent evaluation and for our training. So we basically could not have done this without the Healthcare Foundation, and we really owe them a debt of gratitude. The training that we set up for this, we borrowed from a national curriculum that had developed in other parts of the country, but we refined it for our needs in California. This was not just a cursory training. You can see that there was a core training and site-specific training, and it added up between 200 and 250 hours in total. It was quite rigorous. It was run by the UCLA Center, the Paramedic Training Center from UCLA. It used a national level faculty, and I think that the students and the paramedics in the room here who went through it all felt that it was very strong training and very helpful for meeting the needs of a new type of practice that they were embarking on. But initiating these programs was not without challenges, and they were everything from financial to personnel to not envisioning kind of what the limitations of the rest of our healthcare system were. Like, we don't have any standard for urgent care. We don't have freestanding emergency departments in California, and we don't have any standards for urgent care. So we found that what we thought urgent care could do, they couldn't always do. We had license issues. We had just, you name it, and it came up. And these are just some of the many issues that the individual projects and working with Lou and the EMS authority had to work through to get these projects up and running. I just want to leave you with an idea of the timeline. This has been going on now. We started this project conceptually back in 2012. And there were many steps to this. First, creating the vision, and then going through the soliciting of projects and the application to OSHPD. Finally, getting the projects off the ground. As you'll hear, most of these projects have been running for a year or almost a year at this point. And so where do we go from here? We look at the data. Hopefully the data that you'll hear about is strong, convincing, and speaks to the fact that these are not only safe and effective projects, but they really do add something to our fragmented healthcare system, and would be very helpful for providing patient care and supporting patient care in California. But the next step that we'll talk about later is, well, how do we then take this from a pilot project to a part of our emergency medical services activities for opening it up for all communities and all types of providers in EMS, and that's our next challenge. And I'll bring this up again at the end of our day today. So I thank you very much for all the efforts that many people in this room undertook to get us to this point, but we're not there yet, and we have to, that's why I'm glad to see other people in this room. We hope to energize our other partners. Remember, this was not just about EMS. This was EMS in partnership with other healthcare parts of the healthcare system that we don't necessarily work with on a day-to-day basis. So that's the key there. We have to now get their support to move forward to the next step.